Hello, everyone. Welcome to Doc Talks. I'm Dr. Manju George, the Scientific Director at Paltown Development Foundation, the nonprofit that supports Colin Town. Today, we have Dr. Saima Sharif to tell us about MSI-High colon cancer. Before we get started, I wanted to ask Dr. Sharif how she got involved in doing GI oncology and especially running trials. Welcome, Dr. Sharif.
Oh, thank you very much, Manju. Thank you for the invitation. And this is indeed an honor to be able to speak to patients, their caregivers, and patient advocates about a portion of colon cancer, which is specifically MSI high. And it is, so thank you. Thank you for this opportunity. Now, to answer your question, what was my journey to get to where I am? When I was in medical school, I wanted to be a gastroenterologist. And then my mother's younger sister got diagnosed with breast cancer. And that changed my trajectory. I wanted to change the world. I wanted to do research, and I wanted to make outcomes better for patients. And while I was in training, doing my medical oncology fellowship, I just did not feel like, even though I felt like I wanted to honor the legacy of my aunt, but my heart was still in gastroenterology. And my research mentor, who I am immensely thankful for, and it's Dr. Wang, and he told me, he said, "You still want to be an oncologist?" And I said, "Absolutely." He said, "Why don't you take some time and spend some weeks in the oncology clinic, with the GI oncology clinic?" And after that, there was no turning back. I had found the passion that I had for gastroenterology in gastroenterology cancers. And like I said, I have never looked back, and I have continued to be passionate about research. My research is actually very has always been in early stage cancers. I have a master's in clinical epidemiology, and my goal is to find out what is causing these cancers. Why are we having an increased incidence of patients with younger colon cancers? Why is this shifting? And if it is, how can we better detect them, and how can we treat them in the early stage so we can have more and more patients be cancer free? So this is my area of interest, and that is going to be the talk today. So thank you.
Okay, thank you so much for telling us the story of how you came to be doing what you're doing. Do you want to share your screen?
Sure, absolutely. So let's dive right into it. As I mentioned, that my research interest has always been to do research in patients, or in early stage colon cancers. And I would like to talk today about what are the current treatment strategies for non-metastatic MSI-high colon cancers, and what are the upcoming trials in this exciting area. These are my disclosures. I want to spend a few minutes about the learning objectives, because it looks like a long list, but I think at the end of the talk, my goal is that for patients who have been searching about their cancers, if they are MSI high, I may be able to help answer those questions. What is so unique about these cancers? What is the current standard of treatment? Where is this going? And we can give that credit to the niche trials. I will talk about them and why were they so important to do in MSI high colon cancers. And then there is this role of circulating tumor DNA and minimal residual disease, which is helping and guiding us in colon cancers, in early stage disease, how to monitor them. And the goal of monitoring is to design better treatment, to improve outcomes, and to cure these patients. And then the significance of the atomic trial, when it results, is going to be huge in management of stage 3 MSI high colon cancers. And then there is this topic of wait and watch and non-operative management, which we already have in rectal cancers. Why do we not have this in colon cancers? What are the issues to consider before we start approaching colon cancer with non-operative management, and then finally close with the current neoadjuvant trials that are available for patients to enroll on, and what are the upcoming trials, and what questions they will answer. So let's talk about and start with what is so unique about MSI-H tumors. This slide shows you the cancer statistics. Unfortunately, colon and rectal cancers remain the third most common cancers that will be diagnosed in the US in 2023, and also the third most common reason for cancer deaths in the US. So if approximately 153,000 new cases of colorectal cancers will be diagnosed in 2023, about 106,000 will be colon, and 46,000 of them will be rectal cancers. When colon cancers are diagnosed, the majority of them are diagnosed at an early stage. And this gives us the opportunity to be able to devise and strategize treatment strategies for them to cure them. And as you see here, only a quarter of colon cancers are diagnosed that are stage 4. That is not the topic of discussion today, so I'm going to concentrate on the stage 2 and stage 3 cancers, because these are the ones that may need additional strategies even after resection to be able to provide cure to patients. So how many colon cancers are MSI-H or deficient MMR? So when you look at stage 2 and stage 3 cancers, about 22% of stage 2 and 12% stage 3 cancers are MSI-H. And when you look at stage 1, about 2%, and stage 4, about 4 to 5%. So the bulk of MSI-H tumors are in stage 2 and 3. And I also wanted to mention that I do have active links on my slides, so you'll be able to go and look at the source of the information if you would like to read more about the trials where this data came from. And I also forgot to mention that I will have these take-home points, these bullet points, almost in every slide. So as you're reviewing, and if you want a quick review, you'll be able to quickly look at the snapshot of the summary of what this slide was about. So now we've talked about what the significance is, but what is MSI-H colon cancer? So when you look at MSI-H cancers as a group in over the 4 stages, about 15% of all colon cancers are MSI-H or deficient MMR, and 3% of those have Lynch syndrome. So what is Lynch syndrome? Lynch syndrome is when there is germline mutation in any one of these 4 genes right here. These are inherited, and if there is a mutation in any one of these, this leads to failure to repair errors in DNA, or the cells lose the ability to repair the DNA during cell division, and hence they are called deficient MMR or microsatellite unstable. So I also wanted to point out that DMMR and MSI-H are used interchangeably because they are the same tumors, but it depends on how it is tested we call them either DMMR or MSI-H, and it is okay to use them interchangeably. When patients inherit this gene for Lynch syndrome, which is one mutation in any one of these 4 genes, they also have a higher risk of other cancers, including breast, uterus, ovary, kidney, prostate, and gastric cancers. And so this is the 3% of all MSI-H. What about the rest of them? The rest of them have an epigenetic silencing of MLH1 tumors, MLH1 gene, or what we call a somatic mutation or loss of heterozygosity. These are called Lynch-like syndrome or sporadic Lynch. These are not inherited. These are also, as I said, a deficient MMR or MSI-H. And these do not confer increased risk of other cancers like Lynch syndrome does. So if someone has this epigenetic silencing of MLH1, they do not have increased risk of other cancers. But these also, the hallmark of these tumors are they also have a BRAF mutation. So what I wanted to point out here is MSI high versus MSS, which is MS stable. So if there is no deficiency of the gene, then these tumors are called microsatellite stable or proficient MMR versus deficient MMR if there is deficiency or because of mutation of expression of any one of the protein. It is very important to know that NCCN guidelines currently recommend that MMR testing should be done in all colon and rectal cancers at diagnosis. And usually it is done by immunohistochemical stain that tells us the MMR status, which is very cheap. It is available in any laboratory, in any hospital. It is not a specialized test. Neither is the PCR, but the PCR to test for MSI high is a little bit more expensive, but there is no difference, barely any difference, actually, I should say. This IHC is a very sensitive test to look for MSI, for MMR. And also, I wanted to mention that when the pathology result comes back, there is a process that happens, and I want patients to understand that the process is in the pathology lab, that it takes them a few days to do this testing. So when you initially get your report, it's not going to tell you if you're MMR deficient or proficient. It will say that it has been sent for testing and you need to call your doctor's office a few days later, if you get the result on my chart, or you have then you may want to look for an updated result to know, because it takes a few days for the pathologist to do these stains because they have to run overnight or 12 hours or so. So I just wanted to make that point clear. So let's talk about the current standard of care treatment for MSI high non-metastatic colon cancers. As oncologists, we follow the NCCN guidelines. The interpretation of these guidelines is what make us oncologists, because it looks very complex. But let me summarize this for you, that as of today, whether a patient has dMMR or proficient MMR cancer, resection is what is recommended for patients from stage 1 to stage 3, unless if patients have a clinical T4B tumor. That's when it is recommended that patients should be given neoadjuvant. So prior to surgery, a checkpoint inhibitor immunotherapy. But then also these patients need to undergo surgery. So what is a T4 tumor? When you look at the colon cancer classification, the staging has 3 components to it. Tumor characteristics, the node, which is the N, and M is the metastatic disease status. So in early stage disease, from stage 1 to stage 3, we know that there is no metastatic disease. So what is the T and the N? The T is very important. So what you're seeing here on this picture is the 4 layers of the bowel: the mucosa, submucosa, muscle, and the serosa. It depends not on the size of the tumor, but the depth of invasion, whether it is a carcinoma in situ, T1, T2, T3, or T4. T4 is further divided into T4A and T4B. Whether it just penetrates to the surface, which is, as you see, it is going beyond the outer lining of the bowel, or it adheres or invades the adjacent organ. Why is this important? T4B tumors are difficult to get an R0 resection, and hence they are at a high risk for recurrence, and they have a poor 5-year survival. So the goal by giving neoadjuvant treatment before surgery is to shrink them so the surgeon doesn't cut through the tumor. That's the goal with whenever there is colon surgery, stage 1 to 3, the goal of the surgeon is not to cut through the tumor, but around it and get negative margins. And that's why this is important. So let's talk about the significance of the niche trials and their background. And the background first. What is the background for the niche trials? What we had smaller studies initially in the past showing that chemotherapy does not work in MSI high patients. Foxtrot trial was a large international randomized controlled trial with 1,052 patients that evaluated giving neoadjuvant chemotherapy for colon cancer. very fortunately, this also contained a group of DMMR patients. And these patients were randomized to either getting surgery or getting chemo and sandwich surgery in between the chemotherapy. And as you see on the slide on the right, these patients who were deficient MMR, they had absolutely, majority of them did not respond to chemotherapy. There was maybe some response and tumor, which we call tumor regression grade 1, but the majority of the patients, so about 3/4 of the patients did not respond. So we now have we now had prospective data due to the Foxtrot trial that these patients do not respond to chemotherapy. So while this data was coming out, we had results from this pivotal trial from Dr. Dungley, which completely changed how we approach treatment of MSI-H cancers and clinical trials that are designed from it. She showed that by giving pembrolizumab, which is an immune checkpoint inhibitor, in MMR deficient stage 4 cancers, I only have slides for colorectal, but she included patients who had MSI-H other types of cancers like endometrial, gastric, kidney cancers. And as you see here, the red bars here on the top are MMR proficient, and this tells you the size of the tumor and if there was any change in the size of the tumor. And as you see, there really wasn't any. And here, the green bars tell you the MMR deficient tumors, they shrunk when they were treated with pembrolizumab. And then when you look at duration of how long these patients responded, you see these green lines, they represent MMR deficient tumors, and more than 50% of these patients had complete and durable response up to 730 days, so about 2 years. And this is the data that she presented in 2015. And the same year, and as she presented the very next month, it was a New England Journal article with a link that is here for you to review. So why do immune checkpoint inhibitors or immunotherapy work for MSI-H cancers? So the body has an immune system, but also there is a mechanism to keep the immune system in check so it does not attack its own cells. And there are some immune checkpoints on cell surface to help control the immune response. And they keep the T cells in an off state so they don't harm the normal cells. Now, cancer cells are so smart, they take advantage of these checkpoints to switch the T cells off, thus keeping the cancer cells from being killed. Immune checkpoint inhibitors are drugs that block the checkpoints. So this is what the normal this is what the cancer cell does. It keeps the cells in an off position and prevents them from recognizing the tumor cells. But what immune checkpoint inhibitors do is that they are like the PD-1 and PD-L1 antibodies. They bind to, so you see this red and the yellow here, they bind to PD and PD-L1 and release the brakes on the T cells so they can start to recognize the tumor cells as foreign and kill them. So the niche study design is a very smart way of doing a clinical trial. It's an exploratory study with an adaptive design. What this means is that they define the study population to be non-metastatic I am so sorry. I'm not sure if it was me. Uh,
You did drop off suddenly, so no worries.
oh,
We
I'm so sorry. I think I know where I dropped off.
Yeah, yeah, no worries. We can just edit all of this out, so don't worry.
Okay, all right. So let me get into presenter mode. So I'll start again by discussing. So the niche study design is a very smart exploratory study design it has an adaptive design. And what adaptive design means is that you can look at niche trials as a mothership where it has other clinical trials under the same umbrella. So that's why you hear about the niche 1, 2, and 3. And what they're trying to do is they're trying different combinations of immunotherapy that might actually stimulate the immune system more. So like for the niche 1 trial, they had nivolumab, and they added ipilimumab to this trial. And when you look at the study design, they took 30 DMMR patients, they took 30 PMMR patients, but they split them into two. They gave the 15 of the PMMR and 30 of the DMMR the same treatment, but in 15 of the patients, they added celecoxib to see if that would actually help stimulate immune system, because we know that proficient MMR patients do not have the marker to stimulate the immune system. And unfortunately, they didn't really find that celecoxib added anything, but what they did find, which was very exciting, is that 19 of 20 patients had major pathological response, meaning that they had less than 5% of viable tumor cells left after just 1 dose of ipilimumab and 2 doses of nivolumab. And 12 of these 20 patients had no cancer cells left. So this was very exciting. This led to this trial showed, this is just a summary of what this trial showed. And then this led to the niche 2 study design, in which they actually expanded because initially they were planning on having only 30 patients. They expanded to enroll more patients, and the patients had the same treatment, which is 1 dose of ipilimumab, 2 doses of nivolumab, and within 6 weeks, all patients had surgery. The results of the pathological response are available, and we do not have results of the DFS. This was reported at ESMO by Dr. Chalabi. And the results actually showed that 100% of patients had an R0 resection, meaning the surgeons did not need to cut through the tumor. Patients were able to get to surgery by median of 5.4 weeks. And then it showed that 100% of patients responded when they had their surgery. 95% of them had major pathological response, and 67 had no cancers left or pathological complete response. And when you look at this graph on the right, the difference between the green and the blue lines are that the green lines are the initial niche 1 study that I mentioned, and this is the expanded cohort, which is the niche 2. Those are the blue lines, which show that patients have 100% of patients responded. And then something also very interesting came up in this trial. In the metastatic disease trial, we've seen that there has been no difference of response to immunotherapy, whether patients have Lynch or they have sporadic tumors. But in niche 2 study, we found that patients that had Lynch syndrome had a higher chance of having a pathological response than the sporadic Lynch. I don't know what the reason for that is, but also if you look at the number of patients in the Lynch syndrome, there were only 7 versus 27. So I'm not sure whether, that's the reason why we see this difference. And if there were 27 versus 27, there may be more patients in sporadic, there would be less Lynch patients who would have responded. So I just want you to know that just know that the number of patients of Lynch was maybe 1/3 or less of those that did not have Lynch. But this was a very interesting observation. So then they also, in ESMO 2023, just a couple of months ago, they reported the results of the niche 3 trial. Here, they combined nivolumab to an anti-LAG3 antibody. So as I mentioned, that they are looking at different combinations. So this is in these three, they looked at this combination. Patients had surgery about 8 weeks after registration. In this combination too, 100% of patients responded. That CR was 79%. This was a little bit higher. And 89% patients had major pathological response. There were some adverse events. There were no deaths, mostly related to infusion reactions, which were just minor, grade 1 to 2. So I'm going to then move on to the next thing that I wanted to talk about, which is circulating tumor DNA and testing for minimal residual disease. How is it helping us making treatment decisions for patients in stage 2 and 3 cancers? And what does it mean when they have a positive ctDNA after surgery? Now, for patients who are new to this, I want to go over some definitions. I know patients who have been reading up, and patient advocates and family members who've been reading up may have found the definitions of what all ctDNA and MRD means, but I wanted to go over circulating tumor DNA, what this is. There are 2 types of circulating tumor DNA, tumor-informed and tumor-naive. These are tumor-derived fragments of DNA in the blood, which are not associated with cells, but their main source is the tumor. And that's what we're doing blood. We are taking blood, we are spinning the blood and isolating this DNA. And then there are different ways to do it. In the tumor-informed one, we need the patient's primary tumor for the result readout, and for the tumor-naive, we do not need the patient tumor. And you will hear the term cell-free DNA. Cell-free DNA is DNA that freely circulates in the blood. That is from cells breakdown, normal cells that are breaking down, lymphocytes, other cells from other organs. This includes ctDNA, but there is only a portion of it. But all this, the tumor that is circulating in our blood is called cell-free DNA. Minimal residual disease is small amounts of cancer cells that are left in the body after treatment. So after surgery, after chemotherapy, which is very important for us to know. So, and this is informative in telling us if the patient's tumor and cancer is going to come back or not. ctDNA is a test to look for MRD. Can post-surgery ctDNA help us? When you look at this graph, I want you to look at the topmost portion that is highlighted in red. It's when ctDNA is negative versus ctDNA is positive, there is a statistically significant, it is statistically significant in telling us that this is by far the most reliable feature that we have. We can look at T stage, we can look at N stage, we can look at MSS, BRAF, or RAS in patients, but this alone is more prognostic of recurrence than any other clinical pathological variable in resected stage 2 and stage 3 cancers. So what are the studies? This is a snapshot of the 3 studies that tell us. So if you look at the top graph, in all these 3 studies, ctDNA is negative, but when ctDNA is positive, patients do not, they recur. They have about 80% risk of recurrence. So positive ctDNA is post-operatively is prognostic, and the cancer unfortunately recurs in these patients. Now, what is the impact? So, okay, so we found out if a patient has ctDNA that is positive. How can we help these patients? What is the impact of giving them chemotherapy? So the dynamic trial, which was reported last year, it included stage 3 patients. It was a randomized trial. If you look at the top line, these are patients who were ctDNA negative, and they were only observed without chemotherapy. Those that were ctDNA positive, they actually benefited. If you remember the previous slide, you know how this second line drops precipitously. You can see here that patients that were treated with chemo who are ctDNA positive, there was an improvement in their disease-free survival. We do not have the overall survival results yet from this trial. In the Circulate Japan trial, When patients were ctDNA positive, they got chemo versus not, you can see that there was a tremendous improvement in their disease-free survival. So yes, chemotherapy can help clear ctDNA with improvement in disease recurrence. Now, what happens? So, okay, so we have cleared the ctDNA. What does that do? How does that help people? Do we have data to show? And yes, we do. In the dynamic trial, if patients were ctDNA positive, we gave them treatment and became negative, they did much better than when patients remained ctDNA positive. And the same thing was seen in the Galaxy trial. So yes, ctDNA clearance with chemotherapy predicts lower risk of recurrence. So what happens based on the MMR status? So if you look in the graph on the left, patients, so the green line is patients who are T3N0 but MSI high. So after resection, these patients do really well. But when they are T4N0 and MSI high, they don't do that well, but they do better than patients who are MSS and T4. So even if you look at T4 patients, patients who are MMR deficient do better than MSS patients. The question is, how do we help these T4N0 MSI high patients? And what if their ctDNA is positive? How do you treat them? There is this concerning evidence of lack of benefit of 5-FU. And we don't know the role of oxaliplatin in stage 2 patients who are T4, who have T4 cancer. So if you look here, the yellow line, patients who had surgery alone and they were MSI high, you gave them 5-FU, they actually they did worse. It's like we harmed them by giving them 5-fluorouracil. So yes, there is a predictive value of MMR in stage 2 colon cancer. However, there is also lack of benefit from adjuvant chemotherapy. Going back to the dynamic trial, how did this help us? And this is now randomized data, prospective data, which shows that if ctDNA is negative, so which was considered low-risk patients, if you look at the top line here, patients who were MSI high, they actually had a very good, their risk of relapse was extremely low when they were DMMR, stage 2 patients after resection. But the thing is, these patients were ctDNA negative. So this is another piece of evidence, prospective evidence, that shows us that patients who are ctDNA negative did really well. But again, what do we do with patients who are ctDNA positive? This is unfortunately still an area where there is a knowledge gap, because we know that chemotherapy does not work in MSI high patients. What about stage 3 patients? In stage 3 patients, we have data that shows that when patients are proficient MMR, there is benefit of chemotherapy. But when we look at stage 3 DMMR, we see, there isn't much of a benefit in these patients, or minimal benefit with adjuvant therapy when these patients are stage 3 deficient MMR. So this is where the significance of the ATOMIC trial comes in. ATOMIC trial took patients with stage 3 MMR, deficient MMR, and they were registered and randomized to chemotherapy versus 6 months of chemotherapy with atezolizumab, which is a PD-L1 antibody, and then patients continued atezolizumab for additional 6 months. They started enrolling in September 2017. They have completed accrual in spring of 2023, and these results are eagerly awaited. So I think the results of the ATOMIC trial will be very informative whether the addition of immunotherapy to chemotherapy was of benefit versus just giving chemotherapy to these patients. And for now, until we have the results, unfortunately, this is the standard, which is to either enroll them on a clinical trial, but there aren't any clinical trials that I'm aware of that are going on in this place, because we are awaiting the results of this trial. And these patients now will get modified FOLFOX6 as the standard of care. Let's switch gears to watch and wait on non-operative management of rectal versus colon cancers. So do we have non-operative management for rectal cancers? And the answer is yes. For rectal cancers, in 2020, the NCCN guideline introduced that patients after about 6 months of neoadjuvant treatment, which included 4 months of chemotherapy and 5 weeks of concurrent chemo and radiation, if they have a clinical complete response, those patients can be spared surgery and followed very closely and not have surgery until the tumor starts to grow because of data from the OPRA trial. And just in January of 2023, the NCCN guidelines added dostarlimab or pembrolizumab, or nivolumab, which are 3 immunotherapy agents as preferred neoadjuvant therapy for 6 months for MSI-H cancers, and to give chemotherapy with radiation only in those patients that had persistent tumors. So rectal watch and wait is now standard of care for rectal cancer that achieve clinical complete response after neoadjuvant therapy in pMMR and dMMR patients. So this is very exciting. Now, what about, so this is the trial from Dr. Sursik, which led to the approval of neoadjuvant immunotherapy and rectal wait and watch. She presented data last year at ASCO and was also published in New England Journal of Medicine that 14 consecutive patients with clinical complete response, and none of them needed chemo-RT. Therefore, they're just following these patients in personal communication with her group. She now has 30 or 33 patients, and none of them have required chemo-RT. So we now have the unpublished data for more than 14 patients, and which is why this trial is actually being expanded. It started at Memorial Sloan Kettering. It is now being expanded to other institutions to get more data on patients. So what are the issues to consider for wait and watch and non-operative management in colon cancers? Currently, all stage 1 to 3 colon cancers receive surgery. The clinical staging criteria for rectal cancers are very well established, unlike for colon cancers. Foxtrot trial that I mentioned about, which gave neoadjuvant chemotherapy, used CT colonography, which is a combination of IV and oral contrast, and they validated the criteria for clinical staging, but the uptake, I should say, the uptake of these criteria has been slow. And as more trials are utilizing neoadjuvant chemo and immunotherapy, increasingly more information is being available to reliably stage CT scans. And why is this important? It is important because our goal is not to overstage patients or understage them. And staging right now in colon cancer is very operator dependent until it is completely standardized, but it is getting there. And the other thing which is unique to colon cancers is that when you do a partial colon resection, you do not necessarily have a lot of bowel issues, unlike rectal cancers. But should colon cancer patients have this option if they do not want to lose their colon? So this is what we are exploring in clinical trials. And I think it is time to explore this, especially given the results of the niche trials where patients respond so well to immunotherapy. Do these patients really need surgery? So let's talk about the last portion of my talk, which is the current and upcoming neoadjuvant IO trials and what questions do they hope to answer. I would like to take a few minutes to discuss with you a journey of one of my patients with MSI-H colon cancer. On the left, you see a picture of the colon and its proximity to the stomach and the duodenum. I had, back in February 2017, a 37-year-old patient who had 6 months of crampy abdominal pain and blood in the stool until he was diagnosed with a mass in the hepatic flexure. So this is the right side of the body. This is the ascending colon, and this is the transverse colon. He had a cancer here. And here you see his CT scan. This is his hepatic flexure, and this is his duodenum. So this whole thickening that you see is this big, large tumor. And this is what you see on the colonoscopy. This grayish black is the tumor with blood. And so standard of care at that time, which still was to give neoadjuvant FOLFOX, he got 4 cycles. Not only did he not respond, he had weight loss and developed a fistula, or a connection between the duodenum and the and the colon, and he needed a feeding tube to get beyond this to be able to provide him with nutrition. And very fortuitously, while he was not responding, FDA approved pembrolizumab as second-line treatment for MSI-H cancers in May of 2017. I started him on pembrolizumab on June. 4 months later, you see his tumor shrunk, and in 1 year, you could not even see the tumor anymore. You see the nice bowel wall, which is thin, versus this thickened bowel wall here. So he had no tumor left at 1 year. This was his colonoscopy when he started. This is his colonoscopy 2 years later. The same area, you see absolutely no evidence of tumor. And the patient remains cancer-free to date. So this was one of my patients, and I have had multiple patients in which, because of lack of approval for immunotherapy in the neoadjuvant setting, I had to treat them with chemotherapy. When they did not respond, I treated them with immunotherapy, and they did really well. And these are the very patients who gave me the idea of my clinical trial that I'm going to discuss with you, which is currently enrolling NAIO, which is neoadjuvant immunotherapy trial in MSI-H colon cancer with a non-operative or wait and watch option. So this is a trial, this is a phase 2 single-arm trial looking at the rate of major clinical response and non-operative management in stage 2 and 3 colon cancers after 18 weeks, so up to 6 cycles of neoadjuvant dostarlimab. This is the same immunotherapy drug that was used by Dr. Sirsik in MSI-H rectal cancer patients. So patients will get IV dostarlimab every 3 weeks for 9 cycles. They will have, I'm going to be monitoring them on this study. They will have a study visit, circulating tumor DNA, and CT scan after every 3 cycles. So after they've had 6 cycles, between cycles 6 and 7, they will have a research colonoscopy to see if the tumor has responded. And then if the tumor has responded, CT scan shows the tumor is shrinking, ctDNA is improving, they're not have any symptoms, they will continue up to about 6 months to get IV dostarlimab every 3 weeks, and then we will switch them to the dostarlimab dosing to every 6 weeks, so they do not have to come that frequently. They will get 12 cycles of every 6-week dostarlimab, and so this whole treatment is going to last for 24 months. Now, why 24 months? 24 months because we don't know how these patients will do. We know in the rectal trial, they stopped immunotherapy after 6 months, and they're closely following them. If they continue to do well, maybe there may be a change in the study design not to give these patients 2 years of treatment. But for right now, not having that information, how these patients will do, these patients will have 2 years of treatment. 2 years, 24 months of treatment. The sample size is 25. And this is the link to look at more details of the trial. After they finish treatment, they will come in every 3 months for 1 year for CT scan, ctDNA, and symptom review. This is the study schema. Eligibility is patients who are dMMR stage 2 and 3 colon cancers. They have to have minimal symptoms. Single primary tumor, more than one primary tumor is not allowed on this trial. Our colorectal surgeons feel that we do not want to put patients at risk, and they are high risk of developing metastatic disease if they have more than one tumor. And that is the reason why we are only allowing single primary tumor. Patients need to feel comfortable in foregoing upfront surgery. So we're not forcing the patients. It's the patient's choice. If they feel like they would like to try this approach, then if they are agreeable to not have upfront surgery, those patients are allowed. And also the colorectal surgeon has to review the patient and their symptoms and feel that, yes, we can wait to do surgery, or these patients do not need upfront surgery. So patients will be enrolled. They will have study assessments with these cycles. And if in the group A, if they continue to meet these criteria, they will continue study treatment until the end of treatment. At any point, the ctDNA starts to rise, or they have clinically symptomatic tumor, they will immediately be taken to surgery. And group C, I doubt, and I really hope that we do not have any patients who develop metastatic disease. And this is where the niche trials come in. In the niche trials, they now have 60 plus patients, and none of those patients on neoadjuvant immunotherapy developed any metastatic disease. But still, we have this arm because we need to monitor these patients very closely. The primary endpoint I already mentioned is to look at major clinical response after 6 cycles. What our plan for safety is in our statistical design, it is an optimal Simon two-stage design. We will enroll 11 patients, and we will report the results of these 11 patients before we go to stage 2. Our goal is that at least 6 patients need to have, when they get to their first colonoscopy, we should see shrinkage in their tumor. And if we do not have at least 6 patients, we will terminate the study. So that is our safety endpoint. If patients, if we have 6 or more patients who are responding, we will enroll 14 more. And in those, if 17 out of 25 patients respond, the treatment will be deemed worthy of further investigation. And then we will discuss about increasing the sample size, just like they did in the niche trial. What happens if this study is positive? If this study is positive, is this going to change the standard of care completely? And the answer is likely not. What this will do is, this will give patients a choice. You know, when I'm a patient and I go to my doctor, I know I don't have cancer, but I treat cancer patients, and I know patients want to have a choice. And if the patient says, you know what, do I have to have surgery? Then what this trial, if this is positive, will do is maybe become one of the standard of care options for patients who do not want surgery. There is one other trial I want to briefly talk about that is available within MSI high colon cancers. And that trial is this. It is called Azure 2 trial. I want to point out that this is not a non-operative management trial. All patients will get surgery. And this is a phase 2 randomized trial between standard of care, where patients will have upfront surgery and then have chemo or close surveillance. This is going to be a discussion between their doctor and the patient, and then they will follow up, versus they will get 4 cycles of neoadjuvant dostarlimab, followed by surgery, followed by 6 cycles. And then these patients will be in follow-up. This is the study population. I think this is also a very exciting trial. And this has started enrolling. I don't know how many patients this has, but I can tell you I have 2 patients on my trial right now. One of them has crossed this boundary and is doing really well. The other patient has not reached this point yet, but will in about a month. So this trial is only available at the University of Iowa, but I wanted to talk to you about these 2 exciting trials that we have. And I'm happy to take any questions at this time.
Thank you very much. Despite all the technical problems that we had, I'm glad that, for us to be able to have this talk. Thank you very much. And it was very nice to have the, summary points. So it made following the slides really easy. So we can kind of start to look at the questions. So there are a few. Dave asks, response to PD-1 seems to be linked to the gut microbiome. Why have no trials been done with fecal transplants and gut bacteria pills, as it seems to improve outcomes? Also, not having antibiotics close to starting immunotherapy seems to improve outcomes. What comments do you have?
Very good questions. So I'm going to make sure I hit all of them. So the first one about antibiotics, and you're absolutely right. There is actually interesting data to show that if patients, if the gut microbiome is changed by the antibiotics, it makes a difference. But it can actually also improve response to chemotherapy. It can improve response to chemotherapy, but it can alter response to immunotherapy. So there are so many nuances, Dave, to the gut microbiome that is still being looked at. There are some trials that are being done, but on a smaller scale, because the gut microbiome, like I mentioned, the change in it may help chemotherapy with antibiotics, but on the same note, it may alter it where in immunotherapy, it may change the outcome. So short answer to that part of your question, Dave, is this is a very tricky area. There is research being going on. They are using in some clinical trials, they are also mostly metastatic disease trials. They're using and looking at gut microbiome, and whatever happens in the metastatic disease setting is usually informative for us in the adjuvant setting. So I think stay tuned. You will hear a lot of information coming out in the next couple of ASCOs regarding this. So that was about the antibiotics. Manju, can you tell me what the other?
The next one was about fecal microbiome transplants and gut bacteria pills. Can they improve outcomes?
So yes, this is being looked at to see whether this is going to hurt or harm before we start recommending them to patients.
Okay. The next question is for niche 3. They presented 21% of patients developed endocrinopathies requiring supplementation. Is that more than what niche 2 trial patients experienced?
No, it was not more. It was not more.
Okay, Dave asks again, having PD-1 and CTLA-4 inhibitors seems to have better responses, but also greatly increases side effects. Long-term wise, do we know much about bone damage and arthritis issues and other autoimmune diseases in patients who survive long-term?
Good question, Dave. So immunotherapy side effects, if they are going to happen, they are mostly in the first 3 months, whether they are given for early stage disease or metastatic disease. So we follow these patients very, very closely in the first 3 months. So even though some IO dosing are like for pembrolizumab, for example, you have 3-week dosing, and for dostarlimab, 3-week and then 6-week dosing. For the first 3 to 4 months, we follow patients very closely because the incidence of side effects, whether on the bone marrow, which is very rare but can happen, like aplastic anemia, immune thrombocytopenia, those can happen, but they will mostly happen in the first 3 to 4 months. Now, it doesn't mean it doesn't happen in the long term, but as patients who have received CTLA-4 antibodies and immune checkpoint inhibitors like PD-L1 antibodies are living longer, we are collecting this information. There are long-term studies now being done where we are just following these patients off treatment to see whether there are any long-term effects. We are not seeing anything that is alarming at this point. Like unlike chemotherapy, like long-term, you can see acute leukemias happen because of the DNA damage that happened. We are not seeing that right now, but I have to admit that we do not have the same long-term follow-up of immunotherapy that we have on chemotherapy. So right now, if you ask me today, we're not seeing any safety signal in the long term on the bone marrow. And if it does come out that there is something which I'm not seeing any, that will be reported. But as of right now, we do not have that information.
Okay, thank you. And then we look at one more question. So Dave asks again, we have no idea why some colon cancers are MSI high and most are MSS. They start in the same places, but he's wondering what could be causing them to develop differently. Interesting question.
We do not know the reason. Of course, with Lynch syndromes, which are MSI high, you inherit them, but the majority of the MSI high tumors are not inherited. We do not have any information as to what might have actually caused tumor to be MSI high versus MSS, unfortunately.
Okay, thank you. And then I think the last question from him is, when are we going to stop having chemotherapy as treatment for MSI high colon cancer as adjuvant treatment?
Dave, that question is music to my ears because I'm glad I'm not the only one asking that question, because we have so much data showing that chemotherapy just does not work. But in the it's one of those things that but we know it works maybe a little bit, but we do not have the results of the studies to change that treatment option. So at least in the neoadjuvant, chemotherapy is out. Now in the adjuvant setting, until we have the results of the atomic trial, I think we will unfortunately and regrettably continue giving chemotherapy. And the thing is, so Dave, I also want to mention to you is there are some MSI-H tumors that we know in metastatic disease do not respond. So doing these clinical trials and identifying those patients, because some of them may actually benefit from the combination of chemotherapy and immunotherapy. And that was the reason why the atomic study was designed the way it was. It did not have an immunotherapy alone arm, because we still feel that there is still a role of chemotherapy. And as we get the result of the atomic study, it had 700 patients. That's a lot of patients to look at and come up with doing the translational research on those patients and looking at the markers that they're looking at to see which patients may actually benefit from the combination versus not. So as much as I don't want chemotherapy to be given to MSI-H patients, I think there may still be a role, but I think we will get some answers, if not all, from the atomic trial.
Okay, thank you very much. What are the common side effects seen with 2 years of dostarlimab, or what are you expecting?
So actually, with 2 years of dostarlimab, when you look at the data from Dr. Sursik, the 14 initial patients that she had have actually reached the 2-year mark, almost close to the 2-year mark. And whatever side effects they saw was mostly the thyroid, some infusion reactions, which were very mild, that if you increase the infusion from half an hour to 1 hour, that went away. If patients took like 1 dose of Tylenol, it went away. They felt a little feverish because of the immune stimulation from dostarlimab. And so we're not actually seeing too much from Dr. Sursik's study. On my study, the longest the patient has been on is about 9 months. And other than the thyroid, I did not see any other side effect on this patient. That patient did not even have any infusion reaction.
Okay. And then in your design, because you have, CT scans at specific intervals, and then you have the colonoscopy. So my guess is that once you see a response, and if there is no tumor, then you might, as you said, you might change the how the trial is. You might amend it to have fewer cycles of immunotherapy, right?
Correct. So I'm open. I'm open as a researcher. I cannot ignore the information that is coming out, and I am very closely attuned to what Dr. Sursik finds. And if she finds that after 2 years, patients did not, they had no regrowth of their tumor, then the question would be, should I be giving 2 years of immunotherapy? But also, the other thing, Manju, here is that, yes, rectum is a continuation of the colon, but it does act as a different organ.
Mm-hmm. Mm-hmm.
So yes, that information is going to be very helpful, but the question is going to be, are these patients going to recur? Because we are taking a group of patients who might actually be cured by just surgery.
Yes. Mm-hmm.
So that's where I have to come up with a balance. And it was hard. It was very hard for our IRB to make sure that our trial was designed in a way that was not going to cause more harm. So if you look at, and I put the study, the treatment arm back on here, I wanted you to know that there is a colonoscopy right here between cycle 6 and 7, and there was going to be an end of treatment colonoscopy. Our IRB asked me, if these patients had surgery, when would you do the first colonoscopy? And I said, after a year. And they said, then we want you to put a 1-year colonoscopy after you do your research colonoscopy. I asked them, we had a discussion. I said, would a patient in 2 years want to have 4 colonoscopies, one from the beginning for diagnosis, and then 3 more And I agreed with them that this is a data-free zone. We don't know if the tumor is going to start to grow.
Mhm.
Because we do not have a colonoscopy, a research colonoscopy from here until here. And if patients will get a colonoscopy in between if they develop symptoms. So that's in there. It will be an automatic colonoscopy. If they're having symptoms, doesn't matter if they just had a CT scan, they will have a colonoscopy to see what's going on.
Okay.
But the trial colonoscopy is going to happen here and at the end of treatment. So interesting question. It's also that, time and time again, the colon cancer shows that it's a different, it may be a continuation of rectum, but it is a different organ.
Okay. Okay. Thank you so much. I think we are way past the hour. Thank you so much. Thank you so much again for taking your time to put this presentation together.
Absolutely, Manju. And thank you so much, Dave, for being so engaged and asking the questions. These are the questions that are being looked at, and we are hopeful to get these answers soon.
Okay. Thank you very much.
Thank you. Thank you.
Everyone.
Bye-bye.
Bye.